is board certified in clinical hematology by the University of Milano and in anatomic pathology by the University of Padua. He's also board certified by the American Board of Pathology. He moved to US permanently way back in 1992. It's almost 3 decades ago.
Yes.
He lists 290 peer-reviewed medical journal articles, 72 book chapters and sections, primarily on hematopathology, including 20 chapter sections of the WHO 2016 update on classifications of tumors of hematopoietic and lymphoid tissues. He also lectures extensively during the 5-day tutorial program. In addition, he has frequently directed or presented courses on hematopathology-related topics, including 4 short courses at the United States and Canadian Academy of Pathology and overseas in numerous events. He's a member of several editorial boards. I can go on and on and on, but you'll be more interested in listening to him than his introduction. So now I invite Dr. Urazi to deliver his lecture on chronic myelomonocytic leukemia, diagnostic principles and challenges. Thank you so much, and over to Professor.
Where's my one? Well, thank you very much. I am trying to find my lecture. Let me see. It's on the screen. To close a few things. Okay, almost there. Here we go. Let me just make it. Let me just make it bigger. Can you see it?
Yes, sir.
So I will start. Okay, first of all, thank you very much. This was a very nice introduction. I'm very happy to be virtually there and to talk with you about chronic myelomonocytic leukemia. What I'm going to say is really the post, well, I don't know if that's a good way of saying, but it's a post WHO 2006 concept. So you will notice that several things are not in the blue book, and that's the purpose of my talk, to provide an update and give a flavor for what's going to happen in the next probably couple of years. So I have nothing to declare, unfortunately, and let me just move. Okay, so let's get to the definition. So I changed a little bit the definition from what I used to give before, but there are reasons. So let's go together on this. So CMML, chronic myelomonocytic leukemia, as you know, is a clonal hematopoietic malignancy. It's classified as subtype of MDS-MPN, the so-called overlap myeloid neoplasm group, but is also at the same time a chronic leukemic disorder and has monocytosis as its major defining feature. It's an exception among other disorders because the majority are defined on the bone marrow. But in reality, CMML, historically, at least, has been defined largely on peripheral blood findings. But the most important is this part here at the bottom. Its diagnosis relies on a multi-parametric approach. So in spite of all the advances we had in molecular genetics and so on, we still need a multi-parametric approach for this diagnosis. Why? Because first of all, we have to exclude reactive monocytosis. Once you have excluded this reactive, you have to exclude other myeloid neoplasm, which can also be associated with monocytosis. So it's a sort of combination of things that it goes along the way, and you have to play the due diligence. Okay, so diagnostic criteria for CMML. This is my personal adaptation from the Blue Book. I think it's better than this way. 1, persistent peripheral blood monocytosis di more than 1,000 per deciliter, more than 10% more equal, or 10% of the WBC. 2, exclusion of reactive causes. Now, the exclusion happens in 2 ways. Basically, you have to prove clonality. Okay, so clonality means a neoplastic proliferation. If it's non-clonal, it's reactive. That's the bottom line. It's a bit like lymphoma, same idea. The problem is that you do in 2 ways. You infer clonality, you assume clonality based on something, or you prove clonality. So there are 2 ways. Infer clonality, the traditional way is the presence of dysplasia. You find dysplasia in at least 1 myeloid lineage. Obviously, it has to be significant degree of dysplasia. WHO say at least 10% in a given line. Let's say you find 20% of pseudo-Pelger cell in the peripheral blood. Yeah, that would be dysplasia. You find very severe dyserythropoiesis or this megakaryopoiesis, that would be dysplasia. So this is a way to infer clonality. You don't prove clonality, but it's likely clonal. But if the dysplasia is absent, you can still make a diagnosis of CMML, but you have to prove at that point the clonality. And how do you prove clonality in this setting? Well, you prove clonality because you find a cytogenetic abnormality. You find trisomy 8. Here, trisomy 8 is perfectly fine. It's not an MDS defining feature, but it proves clonality. You find monosomy 7, of course it's clonal. Obviously in a significant number of metaphase. If you have 1 metaphase out of 20, we can discuss, but I mean, usually it's not an issue. Besides cytogenetic, the presence of molecular genetic abnormality is important, and we're going to talk quite a bit about that. Now, if everything fails, you can still infer clonality if the monocytosis has persisted for at least 3 months and other causes have been excluded. So you are convinced now that the patient does not have TB, it does not have, an autoimmune disease, it doesn't have anything else who might be associated with monocytosis. The monocytosis is persistent, is actually increasing in number, the WBC is going up, the hemoglobin is coming down, it's got CMML. So it's a way to do it. So 1, monocytosis. 2, exclusion of reactive cause with this very complicated, in a way, algorithm. Now, there is a note in the WHO book, there is the A, refer to the mutation. So the mutation, and here we are not going to use mutation to support CMML versus other type of myeloid neoplasm. Here, the purpose of this note is to tell you how to use mutations to prove clonality, okay? Because these are 2 different issues. One is mutation to prove clonality, the second one is mutation to tell it's CMML and is not a typical CML, is not this and is not that. Okay, so there are 2 different things. So what can you do with mutation to prove clonality? Well, mutations are very common in CMML. So that's a good thing for us from a diagnostic standpoint, because if you do not find mutation, it's most likely reactive. So it can be helpful. Now, the more mutation you have, the more specific you find, the more likely then the patient has CMML. So you can use the presence of mutation, there are some examples here, to support a diagnosis. Now, there is the issue of the chip, because some mutation may be age-related, but we are going to talk about that. So bear with me a couple more slides and we get there. And we discuss why it's not really that much of a problem. Okay, and the third one, after you have find the monocytosis, you have excluded the reactive cause, well, you have to prove CMML. So you have to separate the disease from other myeloid neoplasms because there are overlaps morphologically, as you know. So, for example, CML, BCR-ABL1 positive, if it's associated with a P190 fusion, can have monocytosis, not the 210. The usual one is the 210 in this context, but if you have the P190, you can have monocytosis. So you have to rule out CMML always. Primary myelofibrosis, polycythemia vera, not so much ET, they can have monocytosis. No rearrangement of the eosinophilic associated fusions who are in the WHO. I don't have to read them. I know you know those. And you always have to have less than 20% blast. Otherwise, you are in AML territory. You are not in CMML. Now, there is another asterisk in WHO, is the B. And B explains exactly the concept I was telling you before, that you use the mutation to see if it's consistent with CMML. So in A, use the mutation to prove clonality, okay? In B, use the mutation to say, well, it's probably CMML. For example, if you're looking at the possibility of a myeloproliferative disease with monocytosis, most likely, if you are right, the patient will have a JAK2, carreticle, no MIPO. If you find none of these, yes, it could still be a triple negative disease. So there are exceptions, but in general rule, you can help yourself with the mutation. On the contrary, you don't find any of those, you find SRSF2, that's most likely CMML. Okay, so let's go over this mutation issue in some detail, because I think it's something that is important. So these are in order of frequency, from the most frequent to the top to the less frequent in the bottom. As you can see, you got the CHIP, the clonal hematopoiesis, in normal individual, aging individual, and the CMML mutation. If you look, it's true that most you find in both left and right, but the frequency is much different. So SRSF2, for example, 40–50% of CML have SRSF2 mutation, spliceosome. But if you look at the clonal hematopoiesis of old age, yes, you do find SRSF2, but it's down here. It's at what is 6, 7 position. So it's not that common. The M3TA, for example, is very common in clonal hematopoiesis of undeterminate significance. And you don't really find the M3TA in a lot of CMML. As you can see, it's not even in the table here. TET2, on the other hand, is very common in both, so it's really not very helpful. And so and so. So, again, if you know the frequency of mutation in different disease, I can help you. The other thing is, I don't have time to cover, but usually in clonal hematopoiesis of undeterminate significance, you only have one mutation and low allele burden. In CMML, you tend to have more than one. Very often it's SRSF2, TET2, and AXL1 together, and they tend to have significant allele burden, maybe 20–30% of variant allele frequency. So actually, in reality, you can use them to separate to make sure it's a clonal disease and is not just clonal hematopoiesis of age-related. And the mutation, independently from the clonality issue, once you have decided the patient indeed has CMML, they have a clear prognostic role. So you basically kill two birds with one stone, as we say, because you prove clonality, at the same time you can prognosticate. So it's actually advantageous. The only favorable one is TET2. Most of the other, if not all, are unfavorable. And the more you have, the worse it is usually. If you have a combination, it gets worse. And you can see the survival curves are different. From, for example, XL1 is a very powerful prognosticator, and as you can see here, is at the top. And it shows you how you can separate patients by the presence of wild type versus mutated AXL1. Don't forget cytogenetic is very helpful. And of course, you have to do cytogenetic to exclude CML. You are basically in the Philadelphia chromosome BCR1 negative group here, even if it's an MDS and PN. You have normal karyotype in 60%. That's why the mutations are important there. And if you have abnormality, those overlap MDS, with the exception there is a higher frequency of trisomy 8 in CMML than in MDS as a whole group. Now, if you put together, and this is basically the contemporary way of scoring this patient, the so-called CMML specific scoring system. If you put together, I was saying, cytogenetics, you get 3 groups based on cytogenetic. And if you plug in the mutation, some key mutation, you get this scoring system that is the one from the University of Pavia in Italy. And the separation is very good of the patient. This paper was published in Blood and is highly quoted. So they basically consider 3 groups here: genetic risk group, the low risk, normal karyotype, loss of Y, which is usually age-related as a single abnormality, high risk, trisomy 8 or other abnormality, chromosome 7, complex karyotype, where you make a difference with the mutations in intermediate risk. They have all other abnormality and mutation of AXL1 and RAS at BP1 and RAS1. Then there is bone marrow blast, more than 5%, more equal 5%, a WBC count more than 13,000. We are going to cover that in a second. That's the proliferative type of CMML. The 13,000 per deciliter is the cutoff between the dysplastic type and the proliferative type. Also the transfusion dependency, and this is the way you add up all this to create those curves. Okay, how do you diagnose CMML? So you use the peripheral blood in the beginning. Once you've done the diagnosis, you also use the peripheral blood to prognosticate the patient. The bone marrow as well, of course, in relation to the blast count. I'm talking about morphology here. So from a morphology standpoint, we have 2 types of CMML, the dysplastic and the proliferative. So these are the difference between the two. Why is important to recognize the proliferative? It's not really important to put that in the diagnosis, but they have more splenomegaly, they have RAS, they have JAK2. See, for example, if you have a patient who does not have a proliferative CMML, you would not expect to be splenomegalyc. If the patient is splenomegalyc and he has a dysplastic CMML, maybe he has malaria, maybe he has something else. So it is important sort of to put everything in some kind of, perspective. And we know that the proliferative have more frequent RAS. JAK2 mutation is more common in the CMML proliferative type. JAK2 is present in about 5-10%. It's not very common, but it causes the problem, as you can imagine, in separating CMML from myeloproliferative disease. As far as the blast count, I don't have to read the cutoff for you. By the way, you're getting the lecture because I'm very happy that this can be shared and there is no proprietary issues here. So those are the cutoff. The CMML 0 is a very controversial group. I was not in favor of putting it into the WHO because there was only one study from Germany basically supporting that. But in the end, they end up in the Blue Book. But it's a fairly tenuous. It's not a very well, there's been some paper from Spain saying that it doesn't really, it's not true, that they have a better outcome and so on. So this one is a question mark, work in progress as far as the WHO goes, but the other one are fairly well established. Okay, the blast count in CMML. The blast count in CMML include blast and promonocyte. They are blast equivalent and exclude abnormal immature monocyte. That's the WHO. So those are the blasts. The WHO called them monoblast. In reality, they are both monoblast and myeloblast in CMML. You don't only find monoblast. You can just find garden variety, poorly differentiated myeloblast. This one could be a myeloblast. This is more like a monoblast. It's hard to tell. But the bottom line, they have round nuclei. They are somewhat round nuclei. They're not perfectly round, but they're fairly round. They have nucleoli and they have fine chromatin because they are blasts. So I put this in different kind of graphic for you to make it simple. We also talk about the cytoplasm, but really the cytoplasm does not help much. You can see vacuoles here in the promonocyte, not so much in the blast, but look at this blast here, it's got vacuoles as well. I really don't think you should waste time on the cytoplasm too much. Just focus on the nuclei. They need to be round, they need to have nucleoli, they have fine chromatin, those are blasts. Now, promonocyte. This is round, blast. Promonocyte become folded. You see the fold. Folded. This is very typical. When you see something like this, very typical. folded, sometimes convoluted, nucleoli, same thing, fine chromatin. These are all blast. Blast equivalent, blast. The abnormal monocyte. The abnormal is just a monocyte. But here you got the nucleus folded, but there are no nucleoli and the chromatin is condensed. I don't think this is very nice. The one on the bottom right, this is the better of the two. The chromatin is fairly condensed, fairly dense. The problem with those guys is when you look at the cytoplasm, they're all kind of pinkish gray, they look immature. They don't look exactly like your garden variety monocyte, and so you might be tempted to call this promonocyte. And that's a mistake because those are not blast. So please do yourself a favor, focus on the chromatin, focus on the nucleoli. If there are no nucleoli, the chromatin is condensed. And I think the condensed chromatin is even more important because in my experience, some small nucleoli you can actually find in those, but I'm more concerned if I find a fine chromatin. I think the fine chromatin, in my opinion, is the most important. So anyway, this is the way the WHO does to do. This is what Roba Serjan, well, he tend to present his slide, but it's from Goasken, the paper in Hematology in 2009. See, it's nice because you put together the monocyte. These are the common one in the peripheral blood. The immature, they call immature, same thing as abnormal. Those are not blast. And then you have the promonocyte, the monoblast. Those are all blast. So you have to help yourself out with picture and it requires some experience. You might want to read this paper we did recently, was published in 2020 in International Lab in Hematology by Kati Fukar, Eric C., a bunch of other people from the bone marrow pathology group, and we review blindly slides among us, and without knowing the other guy diagnosis, we reach good concordance in 74% to separate CMML from AML, just looking at blast promonocytes. So the conclusion of the study is that a somewhat experienced pathologist can tell CMML from AML looking at blast promonocyte. What we were not concordant was about the abnormal monocyte. The abnormal monocyte was all over the place. So most people now tend to recommend to not waste too much time with this abnormal monocyte. Just make sure you don't call them promonocyte. And so Kati conclude by saying our results support the practice of combined blast and promonocyte in a single category. So you might want to read the paper. Okay, flow cytometry. Flow cytometry is a very valuable technique, particularly on the peripheral blood. And I tell you why, because it's easier on the peripheral blood to look at the population than in the bone marrow. Bone marrow, there is always an issue also of dilution of the sample. Most of us tend to use the second or third pool for flow cytometry. And so by then, it's all blood you're sucking out from the bone marrow and not really bone marrow. So it's a combination of, it causes poor sample. And quite often, clotting has already begun in the bone marrow. And in spite of having the heparin in the syringe, the sample might not be optimal for flow cytometry. So I think flow cytometry is more, in my opinion, useful in CMML, particularly the proliferative type, if you send 10 ml in heparin from peripheral blood, and you can do this. So the WHO talk about variable abnormal expression in at least two, with at least two abnormality, which the commonest one is overexpression of CD56. You can have aberrant CD2 expression in myelomonocytic cell, obviously the T cell marker, and you have expression of other markers which can be decreased, sometimes increase. Anyway, abnormal, it might allow you to pick up a cluster of cells fit with CMML. That's the traditional way. Now, since the paper from the French group in 2015, this has become popular. The high proportion of CD14 positive, CD16 negative, those are known as MO1 monocyte, and they are the monocyte you find in CMML. You can see here in red, violet, a very nice tight cluster of MO1 accounted for 94.46. The problem with this is the threshold to make the separation is very high. So the blood papers say you need to have at least 94% of the monocyte, MO1 monocyte. And usually what happens is you find increased number of MO1 monocyte, but you don't get 94.6, so 94. So in some cases, you still don't know. Dr. Patnaik from the Mayo Clinic published this paper, and these are from his paper. And just to give you some perspective on this, I told him, I raised my hand, I asked a question when he presented the ASH cup, and I say, or maybe it was the ASH, anyway, and I asked him, and I say, okay, it sounds like a nice way to tell CMML, do you use this at Mayo Clinic? Because it's from Mayo. Say, oh, no, we don't use it. Okay, that's interesting, I thought, because it's a nice writing paper, but then they don't use in practice, so it tells you something about. But anyway, if you want to do flow cytometry, I think is helpful. And these are more or less what I would recommend you focus on and see if it can help you. The bone marrow examination is always necessary in CMML. And this is important because sometimes, particularly in the current molecular era, when you discuss with clinicians, you get into troubles because you want the marrow. Why we want the marrow? We want the marrow because the bone marrow blast count can be less in the peripheral blood than in the bone marrow. Everybody knows that, every hematologist knows that, so why you don't want to be sure, first of all, that you're not doing with AML. I would like to know if my patient has an MDS MPN or has got AML. Wouldn't you? I think so. And this is important also because AML with monocytic differentiation, what we used to call in the past M4, M5, can simulate CMML in the peripheral blood. Because in the peripheral blood, the monoblast type B, type 2, whatever you call the mature, were mostly pro-monocyte really, they can look like monocytes sometimes. And when you do the marrow, you really get scary because the marrow you look definitely as an AML. The marrow finding may suggest need to test for MPN1, for example. So if you don't do the marrow, you won't do it. You don't know they have a normal karyotype, for example, which NPN1 mutated usually have a normal karyotype. The karyotype done on the bone marrow may show inversion cysteine, 11q23 rearrangement, even a T922, which for some reason you didn't get a fish, but now you know you have CML. Or you may find 512 and having a platelet-derived growth factor beta rearrangement. So these are all important information you get automatically in a way when you do a bone marrow with a karyotype. So I think bone marrow has to be done. And it is already mentioned that you can have more monocyte in one of the two compartments. So sometimes you have more monocyte in the peripheral blood, that's usual, but sometimes you have monocyte in the bone marrow. So there is a subtype of CMML called marrow monocytic predominant CMML. I'm going to touch upon this in a while. And it's important to be aware of that. And also it's useful to confirm a suspected diagnosis. Why? Because if you don't do bone marrow, you will never rule out PMF with monocytosis because bone marrow in PMF with monocytosis will look like PMF. You have your giant or large or whatever, bulbous nuclein megakaryocyte clustered together in some fibrosis. But if you don't do the bone marrow, you won't know. And also is useful to confirm a diagnosis of oligomonocytic CMML. These two are discussed later. So let's move on. Bone marrow. The bone marrow is hypercellular, has a very high myeloid erythroid ratio. Usually, you look a bit like CML. You look like chronic myeloid leukemia. The typical morphologic dissociation that Daniel Katowski used to lecture many years ago at Hammersmith is true. When you look at the bone marrow in a sort of superficial way, is very myeloid rich. You don't see the mono because the mono look like myelocyte or promyelocyte sometime or metamyelocyte. So you can't really tell them on the right games unless you are very good morphologist. So you see a lot of granulocyte in the bone marrow, but then you have the peripheral blood, maybe it's got 3,000 monocytes. So there is this sort of morphologic dissociation between a granulocytic rich bone marrow and a monocytic rich PB. And the monocyte, as I said, are hard to see. Even if you go high power, it's hard to tell which is which. And you look at this field, for example, here, okay? Very easy to see the granulocyte, no problem. Erythroid, no problem, right? When you start getting those guys, I mean, I don't know, are those monocyte? These two may be monocyte. They're very hard to tell, particularly not perfect bone marrow. And so that's where the esterase came helpful. We like doing esterase. A lot of people don't do it. If you have good flow cytometry work for you, I don't think you need it, particularly now we have mutation to support. So you have already flow, you have the present SRSF2, you have the monocyte in the PB. Seems to me like it's overkilling, right? You probably don't have to do it. But it worked very well, nevertheless. And we did a paper many years ago, and we found obviously a big difference between CML 922 and CMML. Very high number here, very, very low here. So that's something to remember. Megakaryocyte in CMML. They are dysplastic. Sometimes they are hard to see because there are not that many. It's very variable, the number. It's not like an MPN in which they are increased. Here they can be normal in frequency, sometimes even decrease. But they are dysplastic. And as you know, sometimes they are hard to see. Those are easy. You can help you out with immunohistology. So bone marrow immunohistochemistry for CMML is not necessary, but sometimes can be helpful, particularly if you have bad aspirate, dry tap, fibrosis. This is the combination that we usually do. We don't do all of them, of course. We pick and choose. The CD14 is by far the best marker you can use for monocyte in CMML. As I told you, the typical monocyte of CMML is the MO1 monocyte. By definition, is strongly CD14 positive. So it works much better than in AML. AML blast can have weak 14. They have other markers, 64 and so on. But 14 work really nice here. Those are not so good. The CD163 and the PGM1. You might want to do CD1 to 3 for the plasma cell dendritic cell. I'm going to show that in a sec. And of course, to count the blast, 34 MABC kit can be of some help. So this is an example, nice CMML, morphology on the left, CD14, much more than what you would expect, and myeloperoxidase is also very high. So the CD1 to 3, the plasma cell dendritic cell marker is very helpful to confirm when you find a nodule, like this one you see on the left. They're very common in CMML, not as common as people might think, though. I mean, it's about 10% in reality. My paper was 19%, but it must have been a selected series. I don't remember, quite honestly, because it's very high. It's about 10%. But when you find those nodules, they don't mean much. They are basically monocytic cell, plasma cell dendritic cell, but mature, not the immature one, not the precursor. But the problem is for the uninitiated, sometimes you might think this is acceleration. You might think it's blasting off. You might think this is a cluster of blast or early promyelocyte. But they are not. They are plasma cytodendritic cell, and you can prove that by CD123, that by TCL1 worked very well, it picked them up. By CD303, which nobody used, but is something that in Europe has been popularized. And also they express monocytic markers. So they got 14, they got 43, which is myeloid marker, CD4, and there is a bunch of other antigen expressed. If you're concerned about the precursors, you want to rule out a blastic transformation into blastic plasma cell cell tumor, keep in mind that those have very low MIB1, very, very low, maybe 5%, 6% MIB1. And they also don't have really 56. 56 is usually negative. And so 56 negative, low MIB1, that's not a precursor blastic plasmacytoid neoplasm. It's just a mature, terminally differentiated interferon-producing monocyte, and that's basically what those guys are. So they don't matter too much, but you have to recognize not to call them blast. Okay, now there is this partial differentiation in those cells in CMML. As a matter of fact, CMML seem to respond to therapy with tagrofux, which is a CD123 antibody attached to, I think, a toxin. Is an interesting compound. There are only preliminary data in clinical study, but as you can see, the one from the Mayo, for example, was presented at ASCO in 2019, shows spleen reduction in those CMML patients more than 50%. So they're small size, serious, but it seems like there is some promise in CMML patient with this treatment, which we don't really have a target therapy now for CMML. So this is something to keep in mind. So specific diagnostic setting, very briefly. So I know that you have seen those cases, everybody else. So cases with borderline monocytosis. So you have a patient who might be an MDS, he has a refractory anemia, he's got something going on, he's not reactive, maybe he has a mutation, but you have borderline monocytosis, you don't fulfill the WHO, you don't fulfill the 1,000 per deciliter. So a case like this, 70-year-old, he's got anemia, some thrombocytopenia, 92,000 platelet, anemia 9.6 gram of hemoglobin, macrocytic 106, WC is normal, it's got 12% monocyte. When you do the maths, out of 5.7, you only get to 700. So you only have 700 monocytes per deciliter. What do you call it? You call this an MDS? I don't think so. So we came up with this study. We look at those cases, we publish in Modern Pathology, and we call this oligomonocytic chronic myelomonocytic leukemia. And the key to the study was to do the molecular testing and see if they were different or the same as garden variety CMML with more than 1,000. We discovered they were the same. The other thing is we publish is that if you give at least 2-year follow-up, the majority of those patients end up being CMML. So we have the proof of concept for a proportion of the patient because they moved into CMML giving time, and also the molecular overlap. So what happened is, these were the molecular results in our study. Now, I don't have time to go in detail, but it was very similar. These were the control cases at the top. These were the cases of oligomonocytic CMML, and you can see they had very, very similar frequency of mutation. So very, very similar maps, if you wish. And this was confirmed by an elegant study, very much better than ours, was done later, of course, by a Spanish multicentric group. And they, as you can see, they carbon copy each other. This is a large database of case published in Blood Advances, and the frequency of mutation is basically the same. So the conclusion of the Spanish study was, yes, oligomonocytic CMML is CMML, and we were right, and this is the way you diagnose this variant. So you need to have persistent, I would say more than 3 months history would be ideal, more than 10 or equal 10% peripheral blood monocyte with absolute monocytosis of at least 500. So we would try to keep some monocytosis. That's the reason why it's called oligomonocytic. It's not called non-monocytic. You know what I mean? You still need to have some monocytosis, but it's less than 1,000. You have an appropriate marrow morphology, which is very important. Exclude PMF, exclude other things, and an appropriate mutational signature. So if you have all these 3 combinations, you can call it. There are 2 other things which is worthwhile just touching upon. You might not have heard of this. There is an leukemic CMML, which is basically the marrow predominant CMML. Now, some of those might just be oligomonocytic CMML. So you have a patient with very few monocytes, over maybe the normal limit, or you might have no monocytosis. So anyway, some might just be the same than the one I just told you. You might find the marrow will look like CMML, and you might find the same mutation. It's probably still a variant of oligomonocytic CMML, but it does exist. It's very rare. This is a situation in which you would greatly benefit by doing CD14 staining of the bone marrow to show that bone marrow is packed with monocyte and that you don't have the monocyte in the peripheral blood. And then Peter Valent proposed this term, clonal monocytosis of undetermined significance, similar to what we do with MDS, for patients who have monocytosis, but they do not fulfill the criteria for neither CMML or oligomonocytic CMML. I'll give you an example. You have a patient who have, number one here, you have number two, but you don't have the mutation. Mutation is negative, but you have these two. Well, in this situation, it will probably qualify for clonal monocytosis of undetermined significance if you have a cytogenetic abnormality, for example, to support the diagnosis. So it's a little unclear to me what end up in clonal monocytosis of undetermined significance. I think the purpose is to do something similar to clonal cytopenia of unknown significance, which is also a difficult diagnosis, but we can discuss. There has really never been a study on this. It was just a proposal from a consensus meeting to have a comparable category. Let's not waste time. I'm almost done, I think. Okay, so if you want to read about these variants, there is this paper in Hematologica, published in 2018 by Peter Valent, University of Vienna, who put together a large international group, which included me also, but there was, I think, Dan Arber also was included. You can probably recognize quite a few of the names. The senior, not the senior, because the senior author was also Peter Valent, but the last name author is John Bennett from the US. But you can pick up a lot of European, Andreas Reiter, for example, from Mannheim, and so on. I don't have to read. Thorsten Afferlach was in. And there is a long list of institutions. This one was a nice consensus paper on those variant, a pre-CMML condition you might find of interest in Hematologica. Okay, CMML or MPN? Another question that sometimes come up. Does the patient have CMML or is an MPN with monocytosis? So what's the issue here? Well, the monocytosis occur in myeloid neoplasms, particularly in myeloproliferative disease, and you can see two papers here. The historic one from Elliott and Tefer in 2007 in Leukemia Research, in which he discussed monocytosis in younger patients with primary myelofibrosis, and where is also an adverse prognostic marker. And there is this study 10 years later, same group, Mayo Clinic, monocytosis in polycythemia vera. Those are all patients at disease outset. So they have polycythemia or they have PMF, and they have a lot of monocytes. Now, they're different from our cases, the one we published, where we call monocytic progression. Those were patients like this one. You can see the date, 2002, no monocyte, the marrow looked like PMF, easy to make the diagnosis. Give 8 years, the peripheral blood looked like CMML. So 2002, 2010, 8 years go by, the PB became like CMML, the marrow look more like CMML now. This is what is known as monocytic progression of PMF. Again, is another situation in which you can find monocyte and you might call it CMML. But if you look at the bone marrow, here there is a history. You have to go back in time, look at the initial bone marrow, you can see it's PMF. So this will be a wrong diagnosis. What makes things more complicated is the presence of fibrosis in 20% of CMML. So there are some overlap, clearly morphologically. And if you find fibrosis of this amount, you can see in the lower right, is probably an MF2 here, is a problem because you might think, the patient is often little sprenomegalic. You might think splenomegaly plus myelofibrosis, he's got PMF. Well, it's not PMF. In this case, it's the opposite story. It's CMML. But if you look at the marrow carefully, it doesn't really look like PMF. You don't find the MEGs, you don't find anything, and there is no history of PMF. So how do you deal with this? It's a rare situation. Most often is when the patient is JAK2 positive. If the patient is not JAK2 positive, unless you're really unlucky and you find a triple negative, PMF, it can be difficult. But otherwise, if he's got MPL or K-reticulin mutation, that's an MPN because they're really not seen in CMML. So you can help you out with a mutation. You can help you out with the flow cytometry. In the Patnaik paper, none of the MPN with monocytosis have more than 92% of MO1 monocyte. But you see, again, we are fiddling with numbers here. You got 94, 92. I mean, this is not as accurate. And flow cytometry enumeration, as you know, doesn't really work well for blast, for example. So why would be so perfect here that you can tell just, this and that? I think you still need to put everything in a context. Okay, so I already mentioned this. Presence of JAK2, MPL, or K-reticulin mutation tend to favor MPN over CMML. Particularly, I would say MPL and K-reticulin. The JAK can be in both. However, in CMML with JAK2 mutation, the vast majority have a very low allele burden. So let's say you have 5% for the sake of argument. That can be CMML with JAK, but if you have 50% allele burden or 40% for the JAK2, that's most likely 90% would be a PMF. So you can help you out with the type of mutation and the allele burden. And already mentioned about the possibility of using this compound for this particular group of patients, because in the study from MD Anderson, was presented at the ASCO as well. This is an MD Anderson study. The other one was the Mayo study. This PMF with monocytosis, as I told you, is a very aggressive subtype, has a bad prognosis, and they suggest that this one can be helpful as well. Okay, now we are making everything very simple, but it's not, as you know, and there are rare patients who really you can't tell. So it's what we call a gray zone myeloid neoplasm, borrowing the terminology from the lymphoma, because, there are situations like this case I'm showing to the right, which was in the study, in which you have very high allele burden for MPL mutation. But at the same time, you have perfect CMML signature with AXL1, SRSF2, TET2, and RAS. So, and a normal karyotype in spite of all this mess. So normal karyotype, very messy and complex mutagenic profile, and the morphology, good luck with that. If you look at the degree of fibrosis, there is even osteosclerosis here. You probably go MPN, I would, but if you look at the morphology in the lower left, the megs are kind of small, they are squeezed by the fibrosis. It's very hard. And in the end, this was called, I think, favor MPN because of the MPL. The MPL, the thrombopoietin receptor gene, is really never been really published in CMML. It's really an MPN-associated mutation. And when we check the database from Munich, thanks to Dr. Thorsten Afferlack, he could not find any single case of CMML with the MPL in the Munich database. So I feel fairly confident this was actually PMF, but for purpose of this paper, it was called a gray zone because we weren't sure. So there are those, okay? And don't feel bad if you can't tell what they are. You have to give the clinician the two possibilities. Could either be this or that, and maybe some suggestion how to approach the follow-up for the patient and maybe even therapeutic indication. For the summary, this is my last slide. So summary for CMML, kind of take-home message. Morphology is still important. Don't forget both the absolute and percentage value for the monocyte are both important. You have to fulfill both. The blast count include pro-monocyte. Flow cytometry may provide useful information. You might want to perform esterase in selected cases. I don't mean that you need in every case. And if you have a dry tap, CD14 is helpful in confirming CMML in bone marrow biopsy. Oligomonocytic CMML and marrow predominant CMML exist. They're not very common, but you should learn how to recognize them. And they need basically molecular confirmation, I think, in my opinion. Get into the habit to exclude PMF from monocytosis if you find fibrosis. And this is true mostly in the JAK2 positive or in the triple negative, because the carreticulin and MIPL mutation usually indicate in the patient's PMF, so you don't have to waste too much time. But if it's a JAK2, it could still be CML with JAK2. In addition to excluding BCR-ABL1, which is always a good thing, in my opinion, I mean, I would sort of recommend the WHO to put clearly BCR-ABL1 negative in the table rather than just say excluding CML. But anyway, I think molecular studies are helpful in specific diagnostic settings. So if you have this diagnostic setting, you should use molecular. And the good news, you don't have to repeat a marrow. You know, those are next generation sequencing studies. You just send peripheral blood. So CMML versus MDS and PN with ring sideroblast and thrombocytosis. You have some patients who have ring sideroblast. They have monocytosis. You don't know which is which. So it might be helpful to you knowing there is an SF3B1 mutation in combination with JAK2 in MDS and PN with ring sideroblast and thrombocytosis versus, for example, SRSF2 mutation in CMML. So I think that's helpful. CMML versus a typical CML versus CNL. There are cases who are not clear-cut. There are CNL patients, for example, who have gone into the disease for a while before coming to your clinic, and they have a few blasts in the peripheral blood, some dysplasia. You know, you're not supposed to have blasts in CNL or dysplasia, but, you know, they acquire that during the course of the disease, myeloproliferative disease. So sometimes they're not that different. And again, I think the molecular signature might help to tell which is which. And then CML versus PMF, I already spoke at length on this. I think with that, I will conclude here, and I thank you very much for your attention. I hope it was not too chaotic or too messy, but I did my best to clarify some of the topics. Thank you.
Thank you so much, sir. This was very clear, very comprehensive. You made a very difficult subject very easy to understand. A lot of doubts have been clarified. Grateful to you. So now we have Indian faculty who have their difficulties to ask you some questions. Dr. Tejinder Singh.
It was a great talk, and so much information was given in a very short time. Thank you so much, Professor Urazi.
Thank you.
I would like to know that there are cases of acute leukemia, M5B, acute monocytic leukemia, especially and whenever there is a little bit marrow fibrosis in them, we don't get a good bone marrow aspirate. And as a result, flow cannot be done. And there is always a confusion. Are we dealing with a case of CMML, or we are dealing with a case of acute monocytic leukemia, M5B? Can immunohistochemistry help in such cases?
Yes, but I think you have to do two things in this situation.
Yes, sir.
You know, if you have AML, I mean, some pro-monocyte will spill over in the peripheral blood. So I really think, honestly to God, you have to go back to the peripheral blood and try to do flow on the PB, do molecular on PB, do cytogenetic on peripheral blood. Now, when you have exhausted all this approach, because it might carry the day, you know, you might find an 11q23 in a couple of blasts in the peripheral blood. Hey, that's AML, right? I mean, 11q23 rearrangement is AML, it's not CML, it's never been reported. You might find an MPN1 mutation in peripheral blood. So, but let's say this peripheral blood is really odd. There are very few blasts, you can get anything out of that. And you only have the bone marrow fibrotic. This is a very difficult situation because I personally think that telling blast the M5B, the pro-monocyte, we're talking really about pro-monocyte, by immunohistology is tough because 14 could be a monocyte. Right? So you could have CMML. So you can try with a kit. That's the reason why I put CD34, CD117 as well. So I would definitely do CD34. I would do CD117. If you're lucky, they express 117. That should not be on mature monocyte, as you know. So they can help you. I have no experience to do Ki67 to look at the proliferation. I mean, it could be a study. If you have few of those, it would be nice to do it and see if maybe you can use the proliferation, which should be higher in the blast Then in the monocyte, you would not expect they proliferate so much, right? It's not Rosai-Dorfman. You know what I mean? It's not a disease.
Yes.
So I don't know if this answers your question, but I think it's a difficult issue. The other thing is, when you have a dry tap, this sounds like preaching to the core, but just do touch prep, do imprint, dabs, what we used to call dabs in England. Sometimes, you can do cytochemistry, you can do a bunch of things. And you can scrape them to molecular. Okay? Thank you for the question.
Thank you, Dr. Tejinder. We'll take one question from the audience.
Yes.
Dr. Anju Bharti wants to know, a patient of chronic myeloid leukemia on treatment, can the blood smear look like CMML?
I don't know. Probably not, because I would not expect, it could look like CMML in the sense you can have monocyte, but I would not expect them to have commonly more than 1,000 monocytes per deciliter. You see what I mean? You might have 15% monocyte. The patient has cytopenia, post-Gleevec or whatever, and he might be even infected with a virus or something, right? Maybe he's a little immunosuppressed. But hopefully he will not have an absolute monocytosis. It might just be relative. So you have to be careful. Again, if you believe in flow cytometry, which I do, by the way, we do flow cytometry, you should look at them all one versus the rest. They should not fulfill the CMML, the CMML monocytosis kind of flow cytometry result. Although I remember from the HIV infection day, for example, the CD56 overexpression, is very common when you have infection. I don't think you can use that to tell neoplastic in my experience, particularly if you have an infected patient. It's like anything else we do in hematology. Quite often it's the follow-up who's going to help. So you got a sample next week, it might be everything is normal and, that's it. You put to rest and everybody win. Sometimes you have to use technology. You have to prove they're clonal. As I mentioned, you have to shoot out a sample of blood to Quest, to one of the reference lab. If you don't do in-house, you get the myeloid mutation panel. It's expensive. It can be. I not struggle with those. Those clinicians don't care so much when the RT-PCR goes down. You know what I mean? That's the way, of course, you do CML monitoring. So, they don't care so much if you go up a little bit EOS or mono, whatever, if it's in course of treatment. But I think if you want to look into that, is an interesting area for further investigation. But thank you for the question.
Thank you. Dr. Gayatri, your question.
I think you're muted.
Thank you. A lot of questions that I didn't have addressed. So maybe as morphologists, we all think alike. My question is, in the absence of access to peripheral blood smear and marrow cytology, how reliable would the trephine section histology be in evaluating for CMML? And in the same context, if there is an extramedullary location that has been biopsied, how would you approach that? And how would you diagnose CMML in those situations?
They are very good questions. So let's try to make an example with CML, because I think it's the most close that come to mind. Okay, so let's say you have a CML patient. It's got CML, but you don't know it's got BCR-ABL1. It's a bit similar situation where you're asking. So can the bone marrow be used to diagnose CML with 922? Morphology of the bone marrow trephine. Yes and no, okay? You have massive neutrophilia in a typical CML. You need the smear, right? You need to look for dysplasia. The bone marrow doesn't work so well for that. The megs can be small in CML, right? So they're not really micro megs, but they're the dwarf, so-called dwarf megs. They're typical of CML. So you can, yes and no. Here is the same story. Okay, let's say for the sake of argument, you have a bone marrow, it's 100% cellular. It's cellular from here to here. You do your CD14 staining, and you have 15% monocyte. totally packed. The megs are all small, look like micro megs. Most likely as CMML. So you can probably tell it in the report to say the bone marrow is markedly hypercellular. You can, list all the things, and the conclusion will be compatible with CML. But, the problem is, at least in the US, you will need to indicate in the note that submission of peripheral blood for, molecular study is necessary to confirm the diagnosis. I mean, something like that. Otherwise, you go out on a limb. If that turns out to be another disease, you get a lawsuit. It depends a little bit on the context where you practice. But yeah, I think so. I think in some situations you can tell. The beauty of the TREFINE is very helpful to exclude myeloproliferative disease, Philadelphia negative, particularly PMF, which is what we are talking about here. I think all of you know how to recognize PMF. Here we are not discussing the pre-fibrotic, we are discussing really the fibrotic PMF. And so in those situations, yes, look like CMML, is not PMF. The monocytosis, has been there for a long time. They might tell you over the phone that, yeah, it was last year also a little less, but still was there. The patient is getting more anemic. I think you can call it. It's just you have to put together all these, it's like a Lego box. You have to put all the blocks together and build the diagnosis. But yes, I think the answer is yes between, with some question mark. Now, the second question is I forgot a little bit what it was.
The extramedullary.
Oh, yeah. That's very challenging, but it does exist because the problem with CMML is a hybrid in many regards, and it also tend to go outside the bone marrow. Not very common, but the good example is it causes splenomegaly. So why it causes splenomegaly? Because it has propensity to infiltrate outside. Now, sometimes you have those accumulation of plasma cytodendritic cells. So do yourself a favor, stain for CD123, or think of that at least. So yes, when it goes outside, I think if you do CD14, if you do CD123, the question becomes, that's the main question, when it's positive, if those things are positive, the question becomes, is this myeloid sarcoma monocytic type or is this CMML? That's the real $1 million question. Not so much is CMML extramedullary. You want to make sure it's not transforming to an AML extramedullary. And again, if they're plasma cylindritic cell, I think MIB1 might be very helpful in soft tissue or somewhere else, extramedullary, because you will show a low proliferation in monocyte and in blast in general. There are some data in those extramedullary proliferation. The rules are always the same. It's morphology. If it's homogeneous, look all blastic, like myeloid sarcoma, nodule composed of all immature cell, monocytic or non-monocytic, it doesn't really matter so much. That's probably a myeloid sarcoma. But I've seen cases where you can't tell. You have questions. And so sometimes it becomes a little difficult. But you are in the area of question mark myeloid sarcoma. That's the main issue. Now, to tell CMML from something else extramedullary, again, it could be an MPN. It could be the patient has PMF. But, you would expect to find some large megakaryocyte, some megakaryocyte within the infiltration. So the infiltration will be extramedullary hematopoiesis, tendentially trilinear in MPN, like PMF. And in CMML, would be myelomonocytic, not just monocyte, a lot of granulocyte as well. So promyelocyte, myelocyte, metamyelocyte, granulocyte, and monocyte. And that would be the extramedullary manifestation of CMML in the skin, for example. The problem is that often they have plasma cytodendritic cell, and that's a pain because they look more like promyelocytes. So you get worried that it might be myeloid sarcoma. So that's the reason why I do recommend to add CD123 as a routine, because you have to control, if you wish, the denominator. I like to know what proportion of those guys, which I don't like, they look like promyelocyte, they almost look like blast, are plasma cylindritic cell. Once I control them, I can focus on the rest. But and 34. 34 is very important because, if you have tonsil C34, you know what it is. C34 is not always positive, as you know, but when it's positive, it means a blast. So is helpful. I hope this answers your question, but these are challenging. But thank you for asking.
It continues to be a challenge.
it is a challenge. Sometimes you don't know. You have to, I don't know. Sometimes you repeat and you send out for cytogenetic or flow the infiltrate. I mean, okay. Any other questions?
Okay.
You're welcome.
Questions from the audience now. Dr. Varian wants to know your comments on the diagnosis of juvenile myelomonocytic leukemia.
Oh, juvenile myelomonocytic leukemia. Okay, the first comment is please pay attention to the age of the patient. Really, it does not go above, I don't ever remember what the cutoff is, but it's not a disease you find. So make sure you double check the age. Okay, second thing is has a propensity to go extramedullary. So you might end up diagnosing that in the skin or the spleen or somewhere else. But now with the new tables that was put in the blue book has become easier, I think, thanks to Charlotte Niemeyer group in Germany, because you really need to find a RAS abnormality. So it's basically a RASopathy, although it's not a RASopathy in the sense that a lot of those are acquired RAS mutation. They're not constitution. There are also constitution. It doesn't make a lot of a difference if it's constitution or acquired. In this particular context, is the JML who drive the prognosis. But I think you really have to do the molecular. So once you have the monocyte, you are in the right age group, you have increased fetal hemoglobin, and you get a RAS mutation, I think you have the diagnosis. So actually, it's not difficult, but you have to do the molecular. I mean, that's my thought about JMML. And I think the table which is now in the blue book is much better than what it was before. I think it's very clear, the criteria, and I didn't have problem. We are going to have pediatrics, if you are interested in the coming European Association of Hematopathology meeting, which was the Dubrovnik. The Dubrovnik meeting got canceled because of the virus, but we are doing virtually at the end of April. I think the bone marrow day is April 28th this year, and I think it's very actually easy to register and just listen to the virtual thing. And JMML there are quite a few cases. So JMML is going to be extensively discussed by me and Ross Legut in the pediatrics. Yeah, I was given the pediatrics. Nobody wanted to do it. So nobody wanted to do the pediatrics. So I say, okay, I'll do it. Now I am the chair of the pediatric session of the AHP bone marrow day. But we have JMML, and some are really very interesting cases with, there is even one associated with the platelet-derived growth factor alpha rearrangement, which is, I think, pretty unique. So a PDGR alpha rearranged disease, would belong to the eosinophilic group, but it's a pediatric patient, and morphologically, everything else is JMML. So it's a JML patient who does not have a RASopathy, but a FLIP1, L1, PDGR alpha rearranged marrow. So there are interesting cases.
Thank you. Dr. Tara Rosni-Paul, your question.
Thank you, sir. Enjoyed the talk.
Thank you.
Question. You said you still recommend the use of cytochemical stains, non-specific esterase, and that it has to be done on the bone marrow aspirate. Any reason for this, for the correct count?
It's not necessary, but it depends on the context. So if you have a situation in which, you might do CD14, right? It worked very well on the biopsy. But let's say it doesn't stay well. For some reason, it's negative, should be positive. You have a bad day with your machine, the control is bad. Cytochemistry is such an easy thing to do, and it works so well. You have nice, unstained smear. To me, it sounds like a crime not to stain. Now, if you don't have access, it's a different story. My friend Dan Arber, is a very close friend of mine. We have done a lot of things together, me and Dan Arber. He doesn't use it because he's used to California. He spent all his adult life in California, and because of all the politicians they have there, you can't discharge. There are issues with the recycling of the product. I don't know. I don't want to get into chemistry. Anyway, there are issues. So you can't use esterase in California. It's illegal. It's like using a diesel engine without this particular filter. Those kind of things. So not a very scientific reason, but there is some problem. And there they do flow and they do immunohistochemistry. They're very happy. So if you talk with the California, they don't even know what esterase is. But, I come from the old school. I train with Daniel Katowski in Hammersmith, and, in Italy was the same thing. We always do cytochemistry in AML. We found very easy to find the Phi body in myeloblast when our rod is not completely formed. I like it. I find it helpful after chemo to pick up residual blast, for example, in M3, after ATRA. I mean, I am an old timer, so I don't like have extensive panel. I don't do Sudan Black, I don't do those things, but MPO, a butyrate esterase, I really like both of them. And I prefer the naphthyl butyrate esterase to the naphthyl acetate with the fluoride inhibition. But, that's a question of taste. I prefer that. There are people who use the combined staining for the esterase and myeloperoxidase with the two color. There are still people who use it. It's something you have to figure out for yourself. If you like it, it works for you, that's fine. The WHO does not mandate. It's mentioned in the book. It's still in the book, but it doesn't, we say that in the text of the CMML chapter, we say it's helpful, but we don't make it necessary. It's not in the table, okay? So it's not one of the, it's a free country. We used to say in the US, not so much anymore. It used to be a free country, and you do what it fit you best. I think you're allowed. Thanks for the question.
Thank you. We take up a question from the audience again. Dr. Henin Medani. Why are there CD123 positive PDC cell nodules in CMML? And do they appear as distinct nodules in the trephine biopsy? Are they picked up in the flow as well?
Oh, the flow part, I have no idea. I remember when I discussed this with Barbara Bain. I think all of you probably know Barbara, has been very active, for many years, still active, really. She told me that she did not have any information about bone marrow, which is very uncommon, and Barbara doesn't have any information. Even more uncommon, she doesn't have an opinion, if you know her. So she had no opinion about plasma cell-dendritic cell on bone marrow aspirate because you cannot see them. I find it very hard. I don't know what they look like, to be honest, on the aspirate. It's something you find in the biopsy. So if you don't see on the aspirate, I find it a little difficult to believe that flow cytometry will be very helpful to pick them up. You know what I mean? You might pick up monocyte with partial CD123 expression. I'm not so sure they're the same thing. You see what I mean? I think it's tough. So I don't have an answer with that. I don't think you can separate things very, very easily by flow. Plasma cell-dendritic cell from monocyte. I think flow is helpful to confirm the type of monocyte you find in CMML. So it helps you to tell this is not reactive and it's probably CMML. But when you want to know how many are the blast, how many are the promonocyte, how many are the plasmacytic cell, I still think you have to rely on morphology because there is too much overlap by flow. In my experience, you just can't find a way to separate them. With morphology, you can to a certain extent. With cytochemistry, you can to a certain extent because the promonocyte has more esterase than monoblast very often. In the monoblast, you still see the kind of round nucleus. So if you have a good esterase and a good eye, you can actually do the separation probably easier on the esterase, in my opinion, than by looking at the right GIMSA. But I don't know if that's answered your question. It's a difficult question. It will be a nice project. Maybe something that the Spanish want to do. The Alberto Orfao, they have very outstanding flow cytometry there. I think now it's become the leading country for flow cytometry study in a lot of diseases is Spain. They really have expertise. And I think it would be really interesting to do that. I would use a combination of marker, probably. 303 seem very promising, actually, very selective for dendritic cells. So it will be very nice having a scoring in which you know which is which by flow. I don't think we are there yet.
Thank you, sir. Dr. Jyoti Kotwal, your question, please.
Sir, today's talk has cleared so many of our doubts, but I have a small question to ask that should we now include the flow cytometry of monocytes, both subset analysis and looking at aberrancies in people coming with monocytosis with no dysplasia on the peripheral smear as part of the diagnostic algorithm, though it's not part of the blue book as yet, sir?
Well, the problem with that is that we discussed this extensively, you can imagine. We have flow cytometries, there's the clinical advisory committee meeting, we have clinicians who love flow cytometry, they make the pitch. But at the end, the majority of people, including clinicians, actually, the majority of our clinicians were opposed to that because they really thought it was not proved to be superior to morphology. So they didn't really want to put in the table. I mean, it's not in the table. What the WHO says is very minimal. The WHO says you can use flow cytometry to support the diagnosis of CMML. So you need to fulfill the morphology criteria. So you need to have the monocyte, you need to have less than 20% blast, the stuff we already mentioned. I would add now that if you have a difficult case, I would rather have molecular result rather than flow if I can choose. Also, molecular is prognostic. See, I don't think flow is prognostic. With all due respect to flow cytometry is a diagnostic technique. It's very powerful. Maybe it's prognostic in some biphenotypic versus something else in acute leukemia. But in this chronic disease, nobody has shown prognostic role for flow cytometry, to my knowledge. So, with the molecular, you kill two birds with one stone. You make the diagnosis, you confirm the diagnosis, and you have prognosis for the patient. So I think it's more, in my opinion, more advantageous. But I think your point is well taken. Maybe we should consider again to put flow as one of the requirements. The problem is a lot of people don't do flow, or you can argue a lot of people don't do molecular too. That's true. But again, I told you, you can sell that as a prognosticator at least. But it's a good point. And, as I said, we have extensive discussion. This is the kind of stuff you can discuss for hours. And then people are still not convinced one way or another. There are just not enough, I think, hard result to justify. But if work for you and you correlate well with the rest and the clinical outcome and whatever, I think you should, by any means, you should include it. The WHO is a guideline. It doesn't really dictate you how to reach the diagnosis. As long as you fulfill the baseline criteria, like the blast number, the monocyte, the real necessary. It'd be like with MPN, no? You want to have the abnormal, megakaryocyte, hypercellular bone marrow, maybe some fibrosis. Then, you add up and you do what is fit best for your group.
So especially I was thinking for those cases where there's no dysplasia and it's satisfying the criteria and we want to wait for 3 months even if the molecular is negative. So rather than waiting for that 3 months for the monocytosis.
You can do flow.
So we can do flow at that time and get an idea and maybe tell the clinician and the patient a little early that it's likely to be a CMML.
Definitely. You can also use flow to support the need for the molecular test. You can leverage it. You can say, well, yeah, it could still be reactive, but hey, flow is really bad. It's very abnormal. So let's get molecular. You can use that as leverage. The other thing people forget about sometimes, I think you know, so everybody knows in this room, virtual room, but it's worthwhile mentioning. When you get a baseline assessment and you got flow, it's very powerful when the patient relapses in the course of therapy because you can pull out electronically, the scattergram and compare. It becomes very powerful because you see the clone. You see the clone going down, coming back up. It's a great way to monitor the disease. So the monitoring capacity of flow cytometry is under-evaluated, in my opinion, and it's something that should be discussed in different diseases.
Thank you, Dr. Jyoti. Dr. Jain, please.
Dr. Orazi, a wonderful talk. Awesome. It just covered everything. I have a conceptual question, regarding this nodules of plasmacytoid dendritic cells that we see. Are they reactive or clonal? And if they are clonal, why do we not see them more often than we usually? It's so low percentage of the times that we actually see them.
Okay, this one I can answer. So they're clonal because they have extracted them. Fabio Facchetti has done many studies and he has published in several papers. So they've been separated, in some way. I don't know if they did cell sorting in some, bone marrow study or some other tissue. But the bottom line is they're clonally related. So they share the same fish abnormality. So there is a formal proof that they are the same clone. And I think it's mostly based on fish study, on selected population. Now, is a differentiation of the monocyte. It's like an hyper-mature monocyte who sort of transition into the plasma cell-dendritic cell. It become an interferon-producing cell. Why it doesn't happen more often? I don't know. It's a good question. It's like saying why an M5 can be A or B. Why an acute leukemia produce more pro-monocyte than monoblast? Okay, why is able to differentiate a little bit more? It's a very interesting question. We believe it's differentiation. So they are more differentiated than the monocyte. They are even more mature. It's a bit like, give an example, a monocyte, go into the tissue, become a macrophage, right? So why they don't differentiate into macrophage in the peripheral blood? I mean, is their genetic program? I don't think anybody is looking to that. And this is an excellent point because, they're actually not innocent bystanders. And I think your question is very, very relevant because if you have too much of that, it's really bad, actually. So the bishop doesn't say that, but everybody who has been working on the plasma dendritic cell knows if you have accumulation of those guys in tissue other than the bone marrow, they kill the patient. So they're not blasts, but it's not good to have a big spleen packed with those cells in a patient with CMML. They are part of the neoplastic clone and they have other characteristics who are not necessarily benign. So first thing to remember is they're not reactive, they're chronically related. Second, they're not necessarily good, particularly if they are not in the bone marrow. In the bone marrow, we really don't know. What we've been publishing on the bone marrow is it doesn't matter, it's more like a curiosity. But when they accumulate in skin, widespread in the body, in different compounds, in organ, in the liver, in the spleen, they are really bad. They are associated with a shorter survival. So that's all we know. It's an interesting area of investigation. It's just there is not that many, first of all, it's not very frequent. CML is not the most frequent disease you find. This is only 10% of CML you find the nodule, and much less so extramedullary. So at the end of the day, you don't have many cases to study with, unless you're MD Anderson or Mayo Clinic. They might have. Okay.
Thank you so much. Thank you.
Sure.
Dr. Varazi has given me certain time and we are left with few minutes out of that. I still have one faculty here. So Dr. Swati, all yours now. Last question. Dr. Swati, unmute yourself. Or bring the mic closer to your mouth.
Now?
Yes.
Yeah. Yes.
So it's always nice to have an interactive session with Dr. Razi. I may be the last faculty to ask the question, but my question is going to start at the very beginning. And that's about the classification.
Sure.
So we know that CMML is an overlap between dysplasia and proliferation, right? And then yet we want to classify as dysplastic CMML and proliferative CMML. So when by definition it is an overlap, then why do we split it into dysplastic and proliferative? Because it's always there in the marrow. You always see dysplasia. So
yeah, I mean, it's correct. It sounds like an oxymoron, but you need to consider that we have many of those in the pathology classification. Think of the pre-fibrotic PMF. I mean, isn't that an oxymoron? I mean, if it's PMF, primary myelofibrosis, then there is no fibrosis. You know what I mean? It's like when you say nasal type extranasal. I mean, we like those things. We like something that is the opposite of what we say. So that should be okay because it's done in many, many other fields. But I agree with you. The problem with this is very simple, actually. It's not really a different subtype of the disease. It's just a manifestation which is associated with a more aggressive clinical course. So the traditional way was to call it proliferate subtype to indicate that they do worse. I tell you the reason is, I think most, in my opinion, start as oligomonocytic. They transition into the dysplastic type. See, we're not there yet to write in the classification, but I would think you have a pre-CMML phase, like you have pre-PMF. And we also have pre-ET, although nobody recognizes because this is open another issue that an essential thrombocythemia the cutoff of 450 doesn't really work for young patient. It doesn't work for old patient either. So it's not that different, but let's not go out of the track. So the question is, why is this? So you have an oligomonocytic CMML, okay, in which you have basically neither the monocyte more than 1,000. Yes, you have 10%, but that doesn't really matter. So you have less than 1,000. Then you go up into CMML, and it's the dysplastic type. Then you acquire RAS mutation or JAK2 or something else, an additional driver, and it goes proliferative. See, that would be the logical scheme. Now, it might not happen in every case. Nothing is very simple in biology or medicine, right? But I think that's the way conceptually to understand. Look, there is another example, RAS. So you have refractory anemia with ring sideroblast, right? You have the SF3B1 mutation, fine. You acquire JAK2, become a RAS-T. Now, Malcovati has published several of those in Pavia. So the staggering of the mutation changed the phenotype. In this situation, is partially justified, I think, the proliferative subtype because you have RAS much more frequent. No question that the only RAS mutated CMML are the proliferative type. They usually end up blasting off, by the way, because the RAS is bad. So I think you have to split them somewhere. Why they split at 13,000? That's a good question. 13,000 is one of these magic thresholds who come up here and there. For example, is there in a typical CML, right? In a typical CML is there, you got 13,000. Why is not 10,000? 10,000 probably the higher WBC, but I think they wanted to have some leeway. Why is 25,000 in CNL, in chronic neutrophilic leukemia? Why is 25,000 you need WBC? Why is not 13,000? This is the problem we're struggling with. So your question is perfect because it goes into the issue of diagnostic boundaries, which I am very passionate about because I think we have to redefine the boundaries now that we have some genetic signature finally. So we can make it the box is a little more flexible. I mean, come on, if you have a patient with 420,000 platelets and he has a calreticulin mutation and he has a thrombotic event, isn't that ET? I mean, come on, we have to be a little realistic here with the classification. So what would you suggest to do? I mean, I agree, but I think dysplastic versus proliferative was the idea. The exact term will be predominantly dysplastic manifestation with predominantly proliferative manifestation. But I mean, it became very long. I don't know if you have any suggestion, but I think it's worthwhile recognize. Now, do you have to put that in your report? I don't think so. I think you can just call chronic myelomonocytic leukemia C note. And in the note, I usually put those kind of things. I say, well, the blast count is this and that. It's supposed to be a proliferative. It's got 15,000 WBC. It's got a big spleen. Maybe you have to test for RAS if you haven't done it. You know what I mean? I put in the note. I don't like to make too complicated the final diagnosis. I like to identify the disease for the clinician because I think it's just confusing. I like to call something polycythemia vera, PMF, CMML, and then I put the note. But that's the way I do it. It's not really standardized.
So since you asked for suggestion, may I suggest that the next blue book we do away with CMML 0?
I agree. Because I didn't want to put that in the first place, but it's not my classification. You know what I mean? You have to listen. And there was a lot of pressure. Well, since you want to know, there was a lot of pressure from our German contingent. So they were very, they have a large database. I think it's still the Düsseldorf database of Ulrich Germing, Professor Germing, and they did a study and they found, a better outcome, but it has not been confirmed. It has not been confirmed. We haven't seen that either. So I am with you. I will get rid of. Maybe we will get rid of. I don't know. It's hard to say. Consensus meetings are very hard because you make a presentation and there is another person who does the counter. They put together two people who have opposite view, and then there is a vote. Some of the stuff get voted, some doesn't. I don't remember this in particular, but I know there was some controversy at the time of the clinical advisory committee, and this was before the Spanish study. Spanish study came after the WHO, invented a 0. I agree with you. I will get rid. I think complicating things too much doesn't help anyone.
Right. Thank you.
You're welcome.
Thank you so much, sir. Sorry, we have exceeded your time by 5 minutes, but it was so interesting, so exciting. And you spared so much time to educate your Indian colleagues here. Very interactive session, enjoyed it. And though I'm going to write to you, we have a lymphoma week in September, and I'm going to engage you. And I'm sure you'll oblige us.
Thank you. I want to tell you, first of all, the lecture is available. So I'm sure Professor Agarwal can make it available to all you guys, and you can go over things. I'm sure you pick up mistakes or things you want to clarify. Please don't feel shy, email me, I will reply, okay? So that's the first thing. The second, I enjoyed this enormously, so I thank you again for having me, and I hope this was helpful to you in your daily practice and maybe give idea to write papers or doing other things. I find a fascinating area. I like all myeloid neoplasms, not because I don't like lymphoma, it's just that is the area where I've been publishing most, and so, you know, I'm more familiar with. But it's nice being together, and I thank you again, and thank you particularly, Professor Agarwal, for inviting me. I mean, it's a great honor. You're a wonderful, very interactive, extraordinarily smart group, and I congratulate you for all you do.
Thank you, sir. Thank you, and have a great day ahead. Thank you.
Thank you. Bye-bye.
Bye-bye, sir.
Bye-bye.
So we move on to the second lecture of the day. Dr. Pradeep Suri has already been introduced, and now he's going to speak on novel WBC parameters in clinical diagnosis. Over to Dr. Pradeep Suri.
Dr. Suri, please unmute.
Hello.
Yes, Dr. Suri, you can share your screen.
Right. Good evening, everybody. Am I audible?
Yes.
Yeah. So, firstly, I would like to thank Dr. M.B. Agarwal and the Mumbai Hematology Group for giving me this opportunity, sir. It's always a pleasure to speak at the Mumbai Hematology Group. And secondly, it's even more sweet because my guru and guide, Dr. Tejinder Singh, is here as a faculty. So it's, you know, a double honor for me to speak in front of my guide. So the topic that I've been given today is novel WBC parameters. So we know that we have come a long way since the era of the first hematology analyzer that was, you know, made by Sir Wallace Coulter in 1956. So we've seen many transitions in the journey from multi-part analyzers to 3-part differential counters to 5-part differential counters, and then, you know, automated hematology counters with the reticulocyte, with automated nucleated RBCs. Some people are giving 6-part, 7-part, and now even multi-part analyzers. So, you know, the list is just endless. But broadly, all the new parameters that are available on the modern analyzers are still broadly classified according to the cell lines, that is RBC, WBC, and platelets. So since the topic is on the novel WBC parameters, I'll be covering some interesting new WBC parameters, which I feel have got a lot of clinical relevance and a lot of traction in today's diagnosis. So broadly, I'll be covering 3 parameters. First is the immature granulocytes, or what they call as the IMG. So this is nothing but a numerical representation of what we call in the peripheral smear as the shift to left. So the higher the IMG value, we got a biological reference interval for it also, the more is the shift to left. The second is the neutrophil Y, or the new Y. Now this parameter basically depicts the amount of DNA and RNA content in a WBC or a neutrophil, and thus is directly related to the fluorescent signal that the neutrophil is generating. So again, the more immature the cell would be, the higher would be the DNA and RNA content. Is pretty much on the same lines. So both IMG and new Y are pretty much parameters which are by and large used to diagnose bacteremia and septicemia. The third in the line is the high fluorescent cell or the HFC. So HFC is nothing but what we used to call earlier as the Turk cell or the Downey cell. Some people like to call it the virocyte, transformed lymphocyte. Basically, it is a lymphocyte that is, activated by primarily the viral infections, although it can also be seen in certain lymphoproliferative disorders. So we'll be seeing how HFC is helpful, especially in dengue, in both prognosis as well as diagnosis. So before I go further, I will just briefly tell the principle of fluorescence flow cytometry. Because of this, we have been able to now differentiate neutrophil, lymphocytes, and monocyte in the X, Y, and Z axis. So the first is the forward scatter or the Z or the Z axis, whatever you want to call. So higher is the forward scatter, the bigger is the cell size. So when I say new Z, I'm meaning that, I'm talking about the size of the neutrophils. The second is the side scatter or the granularity, which is depicted by the X axis. When I say new X, I'm meaning the granularity of the neutrophil. This is another parameter which is very useful in MDS, especially the new X is significantly lower in MDS in compared to the normal population. And last is the new Y, which is what we are discussing today. This is basically depictive of the site fluorescence of the cell line. So higher is the site fluorescence, the higher is the RNA and DNA content. The next thing I'm going to show is the SF cube technology. Basically, this is nothing but the three-dimensional positioning of the different cell lines. If you look at this green area here, this is the area of the lymphocyte. Just above it is the pink area of the monocyte. This sky blue area here is the area of the neutrophil as well as the basophil. This red area here is the area of the eosinophil. Just above the monocyte, these small green dots, this is the area of the HFC or the high fluorescent cell or the virocyte, whatever you want to call it. So higher is the scatter density in this area, the more are the HFC. Likewise, this area above the neutrophil, is the area of the immature granulocyte. So if you see a lot of scatter dots in this area, this is the area of the IMG. So first coming to the immature granulocytes. So the key feature in distinguishing immature and mature stages of leukocyte, we all know, is the NC ratio, chromatin, cytoplasmic quality, the granularity, and we all know the stages of maturation of neutrophil from myeloblast right up to the segmented neutrophils. So in a peripheral smear, what we are likely to see is both the mature neutrophil as well as the band forms. But usually in a normal subject, we would see nothing left of it. But if we see the myelocytes, metamyelocytes, promyelocytes, and even blasts in a peripheral smear, we know that we are looking at either some systemic inflammation and sepsis or worse, bone marrow infiltration. So usually when we compute IMG or the immature granulocytes or a set analyzer, this includes promyelocytes, myelocytes, and metamyelocytes. However, blasts as well as the band forms are excluded from this count. This is a good prognostic marker to detect both bacterial infection as well as sepsis. It can be used as an early marker in the diagnosis of sepsis. And the biological reference interval that we have in our lab is 0 to 0.7%. It can vary slightly depending on the answer and the dye that you use. So if you look at a normal patient, this patient has an immature granulocyte count of 0.1%, which is normal. You can see that this is light blue area, here is the neutrophil area. There is hardly any dot in this IMG scatter area. Contrast that to the scattergram of a patient of septicemia. The IMG here is 5.6%. And if you look at this area here, you can see that there are a lot of dots in this IMG area. So the moment you see that there is scatter clustering in the immature granulocyte area, you know that you are looking at a bacteremia stroke septicemia scenario. And if worse off, if it will be a leukemia, then it will all go as single scatter plot and not into two different, compacts. Next, we have this NUT-Y. So there is something called as the cell population data or CPD, which provides quantitative information regarding both morphological as well as functional characteristics of the three cell lines, that is neutrophil, lymphocyte, and monocyte. And this CPD allows a more detailed study of the cells and detect various variation and response to stimuli, primarily infections. So as I earlier said, Nut-Y is a parameter which is related to neutrophil fluorescence and is a measure of the cellular DNA and RNA content. And it is also a parameter which can be used to differentiate normal patients from bacteremia and septicemia. So this is the paper that we presented in 2020 in the ISLH. It was meant to be in Melbourne, but it ended up being a virtual ISLH for the reason we all know. So the paper was predicting developing sepsis, CVC, and more. So what we were trying to do here was that we were trying to evaluate all these new novel WBC parameters, Nut-Y, monocyte, neutrophil lymphocyte ratio, and immature granulocyte, to see whether they can differentiate A, bacteremia from septicemia, and B, also assess whether they can be used as a prognostic marker to predict severity of sepsis. Or they could be used just like procalcitonin, as the procal values reduce, they wean the patient off the antibiotics. Can, some numerical values be used as a surrogate marker to procal in this study? So what we did was we did the serum procalcitonin for all our patients using Mindray chemiluminescent 960i analyzer. All the hematology parameters were done on the hematology analyzer BC 6800 plus. And the blood culture was done for each of the patient enrolled in the study using Bachelor 3D from Biomedio, France. So what we did here was a simple 4-step methodology. All the blood samples, which were 5,000 in number, were run for CBC on BC 6800 plus, just to get the reference interval of these 4 parameters, Nut-Y, mono-Z, immature granulocytes, and neutrophil lymphocyte ratio in healthy subjects. Further, we selected patients of pyrexia who had registered for us for both CBC as well as blood culture, and only those patients were chosen which met at least 2 laboratory criteria of the surviving sepsis guidelines. And procal levels were ascertained for each of these samples using the Mindray CLI analyzer. We did the blood culture for all the subject patients. The culture negative subjects were excluded from the scope of the study. At this stage, we calculated the Uden index for each of these individual parameters, and we tried to maximize the ROC cutoff to get the diagnostic sensitivity and specificity using the MedCalc software. So these are some of the results in the normal versus the bacteremia group. As you look in both mono-X and mono-Z, there is not much difference in the mean in the normal and the bacteremia group. But when you look at the Nut-Y, Nut-Y shows a significant increase in the bacteremia group compared to the normal subject. This difference was even further enhanced when we tried to differentiate the bacteremia from the septicemia group. So what we got from our ROC cutoffs using Uden's index was that for the 2 parameters which showed the maximum promises were Nut-Y and neutrophil lymphocyte ratio. Nut-Y had a diagnostic sensitivity of 1, which is 100%, and a specificity of 0.93. The positive predictive value was 0.9, and the negative predictive value was 1, and accuracy was 0.96. So Nut-Y was the most sensitive marker amongst all the markers that we studied to differentiate bacteremia from septicemia. Likewise, NLR had a diagnostic sensitivity of 0.86 and a specificity of 1, and a positive predictive value of 1 and accuracy of 0.92. So NLR was although less sensitive than Nut-Y, but was the most specific marker amongst all the markers available. So if you want to screen patient, Nut-Y is the better parameter than NLR, although it is not 100% specific, but it doesn't miss out anything. Whereas NLR cutoff was more specifically able to differentiate between bacteremia and septicemia. We also did a study for the immature granulocytes. Although immature granulocytes was very good in differentiating normal patients from the bacteremia septicemia group, its sensitivity was 100%. But the problem was with its specificity, which was only 33.3%, which means it was not very able to differentiate the bacteremia from the septicemia group. The area under the curve was also 0.6, and the model had poor to fair discrimination. Hence, this cutoff was not clearly able to differentiate cases of bacteremia from septicemia. So our study showed some interesting results for differentiating bacteremia from early sepsis. although we could not find a direct correlation between rising procalcitonin values with any of these subject parameters. So none of these parameters showed a similar increase with the rise in procalcitonin values, hence could not be used as a monitoring tool just like procal can be. However, both mu Y and NLR showed up strong utility in predicting of developing sepsis. The ROC cutoff for differentiating bacteremia and septicemia were 492.4 and 10.66 respectively for mu Y and NLR. So in conclusion, both mu Y and NLR are promising markers to differentiate bacteremia from early sepsis with high degree of accuracy. These markers can become a robust screening tool to diagnose early sepsis and can help reduce both morbidity and mortality. And although these markers are not reliable to predict severity of sepsis compared to procalcitonin, the search for a future marker is still on, where you could use a hematological marker in place of procalcitonin to use it as a monitoring tool. Next we have is the high fluorescent cells. As I earlier told you, these are large lymphocytes that contain a large amount of cytoplasm. Often there is a characteristically bluish tinge of cytoplasm and the cell averts. So this relative lymphocytosis is usually seen in viral illnesses, primarily infectious mononucleosis, hepatitis, cytomegalovirus, dengue infection, now also in the COVID infection. These can also be seen in drug and toxic reactions, immunization, radiations, hormonal causes, certain malignant diseases, idiopathic disorders, certain autoimmune disorders, and graft rejections. So this has got specific traction with dengue infection because it has been used as a prognostic marker in conjunction with the immature platelet fraction in predicting platelet recovery in dengue patients. Usually HFC increases on day 4 of dengue infection. The biological reference interval that we established in our lab for HFC was 0 to 0.4%. Increase in HFC correlates well with platelet recovery in dengue patients, and this can be used as a very useful prognostic marker in dengue along with IPF. It is also increased in other viral infections, but the value is seldom more than 5%. I'll just show you a case of dengue. Day on day, how HFC increases and then finally decreases, and its correlation with the platelet recovery. So this is a patient of dengue which is confirmed on NS1 antigen. This is day 1 of fever. If you look at the platelet count, it is 265. And if you look at the HFC, it is 0% on day 1. If you look at the WBC scattergram, this is the area here, just above the monocyte. There is hardly any dots here. Same patient, day 2, the platelet has gone down to 224. IPF is 0.6. The HFC is slightly increased to 0.1. You are able to see 1 or 2 dots in this scatter area. And still HFC is within the normal range and the platelet is also fine. This is stage 3, platelet 204, HFC 0.2. Again, you are seeing these 2 or 3 dots just above the monocyte. Come day 4, platelet is 161. And the HFC is now for the first time increased to 2.8. You can see in this corresponding scatter plot. Now you are seeing a significant amount of this green population, which is the HFC population. Day 5, platelet 121. HFC has gone up to 11.4. You can see the scatter area in the HFC is significantly increased. Day 6, platelet 126. HFC is at its peak, 23.5%. This scatter plot is even more dense. Day 7, this shows platelet recovery. Simultaneously, the HFC comes down to 10%. So a fall in HFC corresponds to an increase in platelet count in a case of dengue. So more important than even a fall in HFC, we are actually now looking at a jump in HFC. Whenever there is a 3 to 4 times jump in HFC from day to day or intraday, from that time we usually say that the platelet recovery is round the corner within 48 to 72 hours. So this is the study that we presented in ISLH last year in 2019 in Vancouver, where we clubbed all the prognostic markers of platelet recovery in, thrombocytopenic dengue patients, immature platelet fractions, platelet lymphocyte ratio, HFC, platelet HFC ratio, and we were trying to come up with what is the best prognostic marker amongst all these prognostic markers. So the objective of this study was again simple, that we were trying to look at which of the markers, after evaluating all of them, is the best marker for predicting platelet recovery in dengue thrombocytopenic patients, and which of these markers can be useful to clinicians in decision making over a defined period. So what we did was, we had 62 confirmed dengue NS1 antigen or IgM ELISA patients who had platelet count less than 1,50,000. These patients were filtered according to only those exhibiting both rising and falling trends of platelet and other predictive markers. So if a parameter did not have either both rising and falling trend, those patients were excluded from the study. The criteria for significant platelet recovery was an increase in platelet count by 10,000 or 10%, whichever is lower, over the preceding values. And predictive values were classified into peaks, troughs, and falls. So the jumps were taken as at least 3 times jumps over the previous days, and falls were classified as decrease in 50% from the preceding value. So these are the parameters that we measured: MPV, or the mean platelet volume, immature platelet fraction, or IPF, high fluorescence IPF or HIPF, the high fluorescent cells or the HFC, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and platelet HFC ratio. For each of these parameters, we did also measure their peaks and their troughs, as well as for HFC we measured both peak and jump, and for platelet HFC ratio we measured both the trough as well as the fall. So these are the results. So you can see that basically the value which were delta values, the last one, are the most important column, and the 2 important parameters here were the PHR fall or the platelet HFC ratio fall, as well as the platelet HFC ratio, which shows the maximum sensitivity compared to the other parameters. So if you look at within 24 hours, the parameters which are peaked here are the ones which are least useful to us, which means that the neutrophil lymphocyte ratio and the mean platelet volume are no use to us, because their increase is correlating with the actual recovery of the platelets. Rather, the ones which are lowest here, which is the PHR fall and the PHR in totality, these parameters are the ones which are most useful to us. So looking at the delta values, both PHR fall amongst the fall parameters and the HFC jump are showing good sensitivity. So this is the delta value. So amongst the fall jump parameter, PHR fall has a delta value of 71%, which is the highest. So what we established here was that platelet HFC ratio trough had a delta value of 52%, and the platelet HFC ratio fall had a delta value of 72%. So when we combine the platelet decrease along with the HFC in the form of a platelet HFC ratio, the delta values get augmented, and it gives the best sensitivity or the best prognostic marker to look for platelet recovery. Now, we are also looking at HFC very interestingly in COVID infection in 2020. HFC, according to a lot of Chinese data, has usually reduced in COVID infection. The neutrophil lymphocyte ratio is elevated, and there is lymphopenia in the initial phase. Some of the studies have even given cutoff value of neutrophil lymphocyte ratio of about 3.13 to differentiate between mild from moderate to severe COVID infections. However, a subset of patients in our study showed mild increase in HFC after day 5. All these patients in our ongoing study, there were 128 patients, have shown either normal or decreased inflammatory markers, that is the neutrophil lymphocyte ratio, C-reactive protein, ferritin, interleukin 6, and LDH, within 48 to 72 hours of the increase in the HFC values. So we believe that the increase in HFC values may be used as a predictive and prognostic marker in COVID infections to detect either mild disease or a recovery from illness. Both neutrophil lymphocyte ratio and HFC are probably the cheapest inflammatory markers in COVID infection and can be used in places where they have not facilities for more sophisticated inflammatory markers to be tested. So with these words, I'd like to thank you all. And if there are any questions, I'll be glad to answer. Thank you.
Thank you so much, Dr. Pradeep Suri. Excited and learned a lot. Though I'm a clinician, but it was wonderful listening to you and the intricacies of the subject that you covered. So we have some of the faculty here. If they have any question, we'll first ask them till the audience put in some question in the question box. So Dr. Gayatri, Dr. Swati, Dr. Jyoti, if you all have any questions, please go ahead.
Sir, I have a question.
Yes. Tara, go ahead.
Dr. Suri, the NLR ratio we know is increased in bacterial sepsis, but in the COVID infections also we've been seeing this as an increase. So on what basis, I mean, only using these parameters in your studies, can we differentiate early between bacterial sepsis and COVID infection?
So, ma'am, when we did the sepsis study, this was done in late 2019, early 20, before the onset of COVID. So we have not particularly looked at sepsis in COVID patients, but our ROC cutoffs were different. So the ROC cutoffs for differentiating bacteremia from septicemia in the pre-COVID patients was 10.66. Whereas the differentiation of mild to moderate COVID infection, the Chinese cutoff is 3.13. But in our ongoing study, our cutoff is more like 3.6 between differentiating mild from moderate COVID infection.
Okay. Thank you.
Thank you. Dr.
Pradeep, can I ask?
Yes, sir.
I've been following your work since the ISLH time and on sepsis, bacteremia, NLR. But in keeping with the previous session, have you looked at monocytes and their cell population data, their width in various infections? Everybody's looking at neutrophils and lymphos. Have you looked at monos?
So ma'am, we were looking at both mono Z, mono X, and mono Y also in our study. But we could not find any significant correlation, unlike the one that the MDW study is there on the Beckman analyzer. So what I realized was that what we are measuring in mono Z particularly, because monocyte Z is the one that is going to show the larger monocyte. The mono Z study was not giving us good correlation, primarily because our mono Z is more like the MCV of RBC, if I would like to make the same corollary, whereas their MDW is more like the RDW of RBC. So we do not have an equivalence parameter on our analyzer to assess the way the Beckman have done on their study.
No.
Thank you. Dr. Jyoti and Dr. Gayatri.
A very nice study, and Dr. Suri is always doing a lot of innovative work on his cell counters.
Just bring your mic closer to your mouth.
Cell counters and the urine analyzers. And as far as NLR is concerned, maybe it was more, it's more of a prognostic rather than a diagnostic issue in patients with COVID. But I think your HFC data may come in more handy in COVID. That's what I have a feeling. We've had almost 400 beds of COVID, and we have lots and lots of data of CBCs of the COVID. So maybe that would be maybe a better parameter rather than NLR, which is known to be a prognostic, and we did find it to be a prognostic marker. Like that's why people kept it as a marker to decide on admission of patients also.
Ma'am, I agree with you. I find HFC more useful, especially because a lot of these COVID patients have also been given corticosteroids. So once the corticosteroid is given to the patient, then the value of NLR goes for a 6, because all patients on corticosteroids are going to have high NLR. So I found HFC to be more useful. Yes, ma'am, I agree with you on this point.
Thank you. Dr. Gayatri.
Very interesting, and thanks for sharing this information. I have one question that is beyond what you have shared with us today. There was always, initially, everybody mentioned leukopenia as one of the important parameters and the initial abnormality. Have you looked at that versus the your transformed lymphocytes and monocytes?
So, ma'am, patients with leukopenia generally are faring better than patients with increased TLC counts, is what my initial thing is. Barring those patients who develop leukopenia late in the development of sepsis in COVID patients, in the first week of infection, people who are coming with TLC counts of say 2,500 or 2,000 are generally faring better than the ones who are coming out with a count of 6, 7, 8,000.
Did you find any correlation between the leukopenia, the lymphocyte monocyte differential, and the COVID positivity? Did you actually find that?
So, no, we did not look at COVID positivity. We are actually looking at the other way. We are now looking at these parameters in COVID positive patients. So, these are already PCR confirmed COVID positive patients who are coming to us primarily to get their inflammatory markers checked. So, we are not diagnosing COVID per se, but we are trying to look at when these markers, which of one of these would need admissions. So, what I have seen is that patients who have got lower NLR, less than about 3.5, 3.6, are the ones who are more likely to present with an HFC augmented response on day 5, day 6. And these are the patients who are likely to either be managed from home, or sometimes they are asymptomatic people who do not even develop fever.
Thanks. Any other question, please? If not, then Dr. Pradeep Suri, thank you very much. And overall, on my behalf and behalf of everybody, I thank Mindray for supporting our academic activity, and I request them to deliver the official vote of thanks. Over to Dr. Kshama.
Thank you, Dr. Agarwal. I, Kshama Nandode, extend my sincere gratitude to the eminent speakers, the respected panelists, and all the attendees to grace the webinar with your presence. I sincerely thank Dr. M.B. Agarwal to give Mindray a chance to sponsor this knowledge sharing session, which portrays Mindray as a company with scientific acumen. And last but not the least, without taking much of the time, I sincerely thank MICE Ideas and the Executive Committee of Mumbai Hematology Group. Thank you so much.
Thank you, Kshama, and good night to everybody. Thank you.
Good night.
Bye.
Good night. Bye-bye.